Good afternoon. This is Roxana Coleman-Herak, Good Medicine today, and we have a special guest who came all the way over from Helena to visit with us and share a little bit about his knowledge with suicides in Montana. Karle Rosston is here from the Department of Public Health and Human Services. He's our state suicide prevention coordinator, and welcome and thank you for coming over to do this.
Thank you for having me.
Karle, I wanted to start right off. We talked a little bit before the program. The rumor was that we are number one in suicides. Can you kind of speak to that?
Yeah, we haven't had the most recent numbers released, and we're still using 2010 numbers nationally. That's all we have. They haven't released 2011, at least up to a couple days ago when I checked. But I don't anticipate us moving too far out of where we are. I mean, we'll still be in the top 5.
What are the numbers currently? I mean, do we have any current numbers?
Yeah, we have the 2013 numbers just for Montana, and they're still unofficial because the official numbers won't come out till July or August. But we're at about 247 suicides for 2013, which would give us a rate of a little over 24 per 100,000. The national rate is about 12.4. So we're almost double the national average in suicide, and that's where we've been for quite some time.
I know you do a lot of work throughout Montana. What are some of the things that you're seeing in some of the different counties that you go to? Is some areas higher than others?
Yeah, there's usually pockets or clusters that occur in different areas of the state each year. The last, especially for this year, since last November, Butte-Silver-Bow has been hit very, very hard. They've had 5 adolescent suicides since November. The alarming thing for me is all 5 were by firearm. And I think in general, we're seeing more and more kids use guns, and that's alarming. The percentage of suicides by firearm is actually higher for adolescents than it is for the general population.
So what's some of the contributing factors? Why do you think they're turning to guns? What's happening with these kids?
Well, I think it's the reason why guns are so common with Montana, period, compared to nationally. I mean, we know nationally 50% of all suicides are by firearm. Montana, it's about 64%, and a lot of that has just to do with access to a lethal means. I mean, Montana is number 2 in the nation in the percentage of people who own firearms. About 63% of our citizens own a firearm, compared to 37% nationally. So it's access to a lethal means. That's the primary issue.
What are some of the efforts that you're involved in across Montana? I know you're a busy guy.
Yeah, we have a lot of trainings and a lot of programs for just about every age. We now have standard curriculum. I'm on the faculty at the Law Enforcement Academy, and we train QPR, which is question, persuade, and refer, which is a suicide prevention intervention. We train that to all new officers who go through the academy. We also train detention officers in what's called mental health first aid, which gives them a core understanding of mental health issues, but also includes suicide risk assessment, those type of things. So we're training all of our new officers. We are also we have programs for schools, from elementary schools all the way up through high school. The SOS program is one that we use for high schools, and that is an evidence-based program that not only has been shown to reduce suicide attempts in schools, but also increases help-seeking behavior by other kids. So it teaches kids how to recognize it in their peers. In our elementary schools, we have a program called the Good Behavior Game, which we are promoting quite a bit, and that is a classroom strategy that teachers implement that really focuses on teaching young kids resiliency skills, coping skills, conflict resolution, how to express emotions. And the research behind that has shown that over the course of a lifetime, I mean 30 years later, these people that have mastered the skills in 1st and 2nd grade have a much lower crime rate, substance abuse, lower suicide, and much better at managing mental health issues. So that's a program. We also have toolkits for rural primary care providers so that doctors and nurses are trained. We have programs for assisted living and nursing home programs. We have a firearm safety program where we distribute gun locks to community or county health departments. A wide variety. We sponsor what are called assist trainings, which are more in-depth gatekeeper trainings that usually last 2 days that give people a very strong foundation on how to intervene and how to help someone who's at risk.
You know, with all of these different educational efforts that are in place, we still have a growing concern with suicides. And I don't really know what the contributing factors are. It seems that it's high. Our suicide rates are really, really high.
Well,
despite our efforts.
Part of it is if you take a look at the big picture, we've only been doing this a few years.
2007.
Yeah, and Montana's had a high suicide, has been a top tier state for suicide since the early 1900s. And we've been in the top 5 for the last 40 years. But we have a culture of suicide in our state. And that's not going to change overnight. That's going to take a cultural shift in thinking. And one of the major issues that we have that people don't always quite understand is that if we focus on suicide, we're going to miss the boat. It's the underlying issue. Suicide is a symptom of a bigger issue, and that is undiagnosed and untreated mental health disorders, primarily depression, anxiety. And the stigma that we have in our state about we see depression as a weakness, we're a burden to our families if we talk about it. That's where we have to start to challenge that, because in states that have the lowest suicide, those are states that mental health services are well accepted and there isn't the stigma against it. We know that if people receive treatment, that suicide is preventable. And with where we are with our research, depression is now seen as one of the most treatable of all psychiatric disorders. Yet still only about 10% of the people who have that diagnosis ever receive treatment. That's where we have to start to change our culture.
You know, back east, it's cool. I mean, everybody's got a therapist. I mean, you're just not cool if you don't have one.
Yeah.
Here, I mean, because we are so remote, we're so isolated, it's not always as easy to get help as we might think.
And we definitely have a shortage of psychiatrists. I mean, we have a horrible shortage of it, and mental health professionals. But we also underutilize the services that we do have, and much of that has to do with the stigma. There is help available. I mean, there's community mental health centers, and there's primary care, which is becoming more active in treating mental illness out of necessity. I mean, they have to, because we don't have the psychiatrists. But we do have primary care. We do have nurses and APRNs and social workers and LCPCs, and so there is help available. But that we still have to be willing to ask for it.
Do you see in your education that you conduct throughout Montana, do you see people talking about prescription drugs as being maybe one of the problematic issues?
I think it is. I think that there's a lot of issues, especially with some of the painkillers and that type of stuff. And the state has taken measures. I was part of the governor's, when he was the attorney general, he would create a prescription drug task force, and that was to create a registry to prevent people from doctor shopping, going from one pharmacy to the other, that type of stuff, and also to promote prescription drug take-back programs where people are encouraged to go through their closets and get rid of unused prescriptions to kind of reduce the access to it. So there has been some measures, and that's definitely an issue that has to be, it's going to take a while to work.
Yeah, we had a speaker earlier. We had a doctor and a director of nursing that was here talking about some of the policy changes that are going to be implemented and are implemented now in many of the hospitals. So that's one way, hopefully, we can kind of get a grasp on this. What are some of the other trends that you see throughout Montana? Have we always been kind of in competition? I hate to put it that way, but it seems like Montana and Alaska seem to be the two that are
Montana, Alaska,
shifting.
Wyoming. I mean, if you take a look at the top 10 states for suicide, it's all Rocky Mountain region. From Alaska straight down through Montana, Wyoming, Colorado, New Mexico, Arizona, Idaho. I mean, they're the top 10. So, and there's a number of issues that we are challenges to us which aren't going to be easy to go against. One of them is isolation. I mean, Montana has 6.7 people per square mile. The national average is 88.
It feels like that.
Yeah, and the average is 88. So we're isolated. We have issues with the firearms. Access to firearms is definitely part of the Rocky Mountain region. Substance abuse is another big one. Nationally, about 30% of all people who die by suicide have alcohol in their system at the time of their death. The preliminary numbers we're starting to get from Montana, and the sample size is way too small to say for this for sure, but we're right around 45%. So we know the substance abuse is a key issue, specifically alcohol. Not that other medications aren't, but we really see the correlation with alcohol. We have issues with altitude. I mean, altitude is a positive correlation with suicide. Socioeconomic. We have 160,000 people in our state. Almost 17 to 18% of our population does not have access to health insurance, mental health services. And we have almost 20%, I think it's around 18% of our kids live 100 to 200% below the poverty line. So those are all factors that contribute. And then you throw in the stigma that we have, the cowboy mentality of taking care of our own and not talking about our problems. And you throw all those factors in with that stigma. This is not going to be an easy issue to change. It's not going to change in a couple of years. This is going to take a lot of the stuff that we're doing now, such as the good behavior game. We're talking about something that we're looking at the benefits 10, 20 years down the line. And that's kind of how you have to think of it. It has to be a long-term, slow process of change.
What about funding? Does it look like there's going to be any additional funding over the horizon with mental health? I
don't know. I don't know about mental health. I'm hoping that they don't touch mine.
I'm hoping so too.
We are applying. We have applied for some SAMHSA grants for the Garrett Lee Smith Youth Suicide Grant, and so we're kind of waiting to see if we get that, and that would be a great benefit if we can. And we'll continue to explore some other funding opportunities as they come up. But I'm at a statewide level. I'm not sure it's kind of hard to predict what's going to happen in a legislative session. We're hoping for the best.
Let me ask you this: what was it that kind of launched you into suicide prevention work?
Well, I've been a clinician for 20 years, so I've worked a lot with youth and with people who are suicidal, probably primarily because I'm also a survivor. I lost a sister to suicide back in 1987, so it's been a place that's been an issue that's been very close to me. And when I was in Colorado, I spent 10 years in Colorado doing a lot of suicide prevention, and I spent a number of years working at Short Air Children's Hospital, doing a lot of suicide prevention, and actually had received a grant to train teachers in suicide prevention even before my position was created. So I was doing some of my job before I was even doing my job.
Funny how that works.
Yeah, so it was there, and it was a good fit for me when this position was created in 2007.
You know, when we do the assist trainings, we always look at this suicide as the tip of the iceberg, and we know about this much about suicide. What we don't know about suicide continues to grow, it continues to flatline. What would be in that layer of what we don't know? Why aren't suicides reported as suicides?
Well, it's interesting that you use that analogy, because in a lot of my trainings I do the same, but I use the iceberg analogy from a personal experience for people, in that an incredible amount of the suffering that a person experiences when the anguish that they feel is unknown to anybody, because it's a private issue that goes on in here, and it's huge. And so people, they see themselves as being alone. They usually aren't able to talk about it, or they don't talk about it, so it's very private. It's something that they go through, and that is huge. And it isn't until it hits a critical or crisis point where the surface of the water is broken. And that usually is an attempt or some type of high-risk behavior, and then we see it. But prior to that, it's a private hell that the person goes through that is very often very private, very isolated, that they don't share and that other people don't know about.
When we talk about this, can we go back to your sister?
Sure.
When you had a suicide in your family and that was your sister, what do you think that the signs of suicide out here are basically missed, dismissed, avoided?
Missed.
What happened with your sister?
Well, my sister had just finished medical school, and and it was one of those things that, to be honest with you, my parents didn't even share with us. I wasn't really aware of what my sister was going through until after the suicide. But then it was afterward that I had found out that it was actually her third attempt. She had been in counseling, she had been on medication, and she had clinical depression, and she had an eating disorder. All of that was stuff that was kind of missed by, I didn't notice it. Part of it was she was 7 years older than me, and so I was 20 when she completed suicide, so I was probably, for the most part, I'm sure I was off doing my own thing being being a kid. Mm-hmm. But there wasn't. My parents didn't fully understand, and they didn't talk about it. It wasn't an issue that was brought out. And I came, my dad was a doctor, my mom was a nurse. And so even within then, there was a stigma associated with it, and we don't talk about it, we aren't going to keep about it, let's just, hope it gets better type of stuff. And I see that, I saw it in my own family, and I see it in families across the state, is that there isn't a willingness to talk about it. They just want to keep it quiet, hope it goes away. And for the person that's experiencing that brings a great amount of shame and guilt and self-blame, like there's something wrong with them. Mm-hmm. And they can't talk about it, so they're just going to withdraw, they're going to isolate. They can't even talk to their own families about it because of fear of being judged. And that's the piece that we have to change. We have to make it okay. We have to encourage people. We have to support them and let them know it's okay to talk about it. And that goes from not only our families, but all the way up through our schools and our primary care. It has to be made okay to talk about this stuff. We know that if people talk about it, that we have a very good chance of reducing the number of suicides.
I'm really hoping we can do that too, because I know there were 2 suicides in my family as well, and one was my grandfather, and we never talked about that until I actually started working in the Circle of Trust program in 2007. My mother, we never talked about it until I actually kind of got involved and kind of started, like you did, talking about the experience that we kind of went through with these suicides and that haunting question, what did we do wrong? What happened? What did we miss? Were we just in avoidance? Were we in denial? What was it? But those things really don't get talked about. So I'm hoping we can open the door wide open so that it's okay to talk about this stuff.
It's interesting because I've done so many trainings that I get a lot of people who call me who have been touched by suicide. And I can't tell you how many people call me and say, I never knew the signs. I never saw the signs until I took a training. And then I go through and I look up the handout with the signs and the symptoms, and it's like a checklist of all the things. And that is a pattern that I hear around the state of after the fact, people say, oh yeah, that was there, that was there, that was there. They just didn't see it then, or they didn't know how to put the pieces together.
Yeah.
And that's really when we talk about QPR and assist and safe talk, all these types of trainings that we have now, all of those are focused on helping people put the pieces together to have a better understanding of it.
It's interesting. I really enjoy, I enjoy doing the assist trainings, and out of all the people that have been trained, there's 2 things that have always been mind-boggling to me. We have a built-in infrastructure, and I know you're going to talk about this, but we have bars in every community. Mm-hmm. We have more bars and churches are the 2 mainstays that you can see in any community. So what are you doing as far as maybe getting some of those bartenders, some of those cosmetologists, of those people that...
That's been a tricky one. We did do something with cosmetologists because, every cosmetologist is an amateur therapist. We did send out, we contacted every single cosmetologist in the state that was licensed, every licensed cosmetologist, and we gave them information on warning signs and what to look for and how to talk to somebody. And we did have a program with the Department of Revenue Liquor Distribution, where we had bar coasters that has stuff on it, but they have a server education program where they're required to train everybody who has a liquor license, and their bartenders, primarily on recognizing someone who's intoxicated and that type of stuff, and fake IDs and all that type of stuff. Well, we were able to, for a period of time, put in some QPR. not necessarily specifically QPR, but suicide prevention training. Here are the warning signs, here are some resources that people could do. We actually got a lot of resistance, so it was a lot of bartenders just felt like it wasn't their job. And I think that's another
what
piece.
They do. It's like it's really listening, but and I don't want to underplay the whole. It's hard to talk about suicide when somebody's drinking. When you're under the influence, it's very difficult to get very far. So I kind of get that. They may not remember the next day that they were talking about suicide the night before.
Right. But there's a large portion, remember, a large portion of people who die by suicide are intoxicated at the time of their death. So it lowers our inhibitions, and it often brings up that impulsiveness, and there's a lot of suicides that occur when they're under the influence.
So, what are some other things? I mean, if you were talking to the audience, and I want you just to imagine there's people watching, and we know that there's a lot of interest in suicide. We know that there's a lot of people who aren't talking about it. What are some things that you can share with people at this point, what they can look for if someone is struggling with thoughts so that those signs are not missed, dismissed, or avoided?
Well, I think one of the first things is there's a tendency to believe that this has to be done by professionals, that this is for a certain type of people, healthcare people that need to do this. This is something for everybody. I mean, there's nobody in our state that shouldn't be trained. I mean, this is for everybody because, I always talk about when I get calls from school administrators, and I say, they say, I want you to come and do a training for our teachers. And I'm like, I'm happy to do that. But I also want school lunch ladies, bus drivers, and custodial staff in there too, because they have relationships with the kids. The thing to understand about suicide, it's very much of a relational issue. It has to do with relationship with your parents, with other people, conflictual relationships, or absence of relationships. But very much from adolescence through the elderly, suicide is very much a relational issue. So that includes just about everybody in our state that has a relationship with somebody else. So recognizing the warning signs, is there a change in their personality? And that's what we're talking about, a change in character. The person's acting this way now and they didn't used to. They start talking about death. There's a change in their sleeping habits. They start to give away prized possessions. There's a sudden interest in acquiring firearms or stockpiling medications. There's a lack of energy or fatigue. There's an increase in their substance use. They start to withdraw. They start to isolate from their peer group, their social support group. All of these are warning signs that people need to pay attention to. A decrease or a deterioration in personal hygiene often is associated with some type of mental health issue that's starting to come up. So all of these are issues that we can't ignore. And especially when we talk about it's a change in how the person used to be. If you see that, don't ignore it. Ask the question. There's a lot of people that are afraid to bring up the word suicide.
They're afraid they're going to plant the seed.
Yeah, they think they're going to put the idea in the person's head. There's not 1 ounce of research to support that. On the contrary, it's a way of validating a person's pain. It reduces the isolation so they don't feel so alone. It's a way of offering hope. It reduces impulsive behavior. I mean, it is truly a way to get to connect to somebody. You can do no harm by asking somebody if they're suicidal. If they are, you want to find out if they have a plan, how they would do it. Do they have the means? Okay, and not leaving them alone. And it's also not something you can keep a secret. Even if they say, you got to promise me you won't say anything, you can't do that. And then you got to take them immediately to help. And that might be taking them to the ER, calling 911, taking them to a community mental health or your local primary care, calling the suicide prevention lifeline and say, I'm here with somebody and we're worried about them. And they will bring help to you. That's how we have it set up. So, questioning, offering hope, and then referring them or taking them to help. That's something that anybody can do.
Now, that suicide hotline number is 1-800-273-8255. You might want to write that down if you, and I suspect a lot of people do know someone watching this program that they may be concerned about and they're afraid to ask. So I'm hoping you will do that. As far as, is there a particular group that's higher than any other group for suicide.
Yeah, in Montana, our American Indian culture is definitely, our American Indian population has the highest rates, right around 27 per 100,000, compared to about 22. I think a lot of times people miss that because if you took a look at actual numbers, it seems low because, you know, out of the 247 suicides last year, I think 37 were American Indian. So that a lot of people will look at that and say, well, that's a low number. Well, you have to remember American Indians only constitute 6% of Montana's population. Montana's 91% Caucasian. And so the number might seem low, but the rate is very, very high. And for many of our reservations around the state, it's at epidemic proportions as far as the number of suicide and suicide attempts that they're having, mostly with their young people.
It's concerning. So what do you do to keep yourself sane? I mean, this you know, and I say that because it's really important. Caregivers make really lousy caregivers when they're not taking care of themselves. I've been there, and I'm sure you've been there. And sometimes the pace can seem so fast and so busy and so hectic that we oftentimes do forget that we need to find ways to take care of ourselves.
I have two kids that are both in high school and are actively involved in sports, so I got to be, you know, go to a lot of sporting activities and that type of stuff. And I'm a basketball referee. I referee high school basketball games, and I enjoy playing and working out and that type of stuff. So I do a lot of those types of things that are kind of coping mechanisms for myself. So I'm gotten pretty good at knowing where the limit is and being able to turn it off and how much to personalize and when to be able to leave it at the office. It'll still be there tomorrow morning when I get there.
That's right.
So,
that's the attitude that I'm hoping a lot of people, a lot of caregivers particularly, will take heed of that. You have to do something to find a balance in your lives. This is very difficult. To care for other people can be very heavy at times, and there can sometimes be a contagion. If you're around depression or people that are struggling all the time, you can easily fall into that. So just be mindful of that. Find ways to keep yourself healthy. It looks like we're about at the end of our program, and we're going to head up to another meeting and stretch you out a little bit farther.
That's what I'm here for.
I appreciate you coming, taking the time to do this program with us. Thank you for the good work that you do throughout Montana.
Thank you for having me.
And thank you for watching.